Los Angeles.
Hopefully we can keep this reasonably interesting and moving along a little bit. The group asked me to speak about head and neck cancer. It's like a reverb or something here a little bit. We're okay?
It sounds
You
fine.
guys are all right. Asked me to speak about head and neck cancer this morning. My name's Bill Carroll. I'm from UAB. Been here in the Oropharyngeal program for 20-something years now, and enjoyed being in Birmingham and appreciate the opportunity to come out and talk today. I'm going to sort of focus this a little bit on some things that are changing in head and neck cancer. We're probably going to focus mostly on oropharyngeal cancer because that's where more of the changes have happened recently. And I've tried to sort of gear this so that there'd be some general interest, and there are not too many slides of mechanistic pathways and things like that that hopefully won't put you to sleep immediately. And if there are questions along the way, please feel free to ask them. I've tried to leave a little bit of time in community for questions as well. I really have no personal disclosures. Our Head and Neck Oncology Fellowship is supported by the Pew Synthes. None of that funding goes to me directly, but I'm the person who's listed as the PI for the process. So as I mentioned, I want to talk a little bit about oropharyngeal cancer today. We're going to talk in the first few minutes about the papillomavirus, the HPV, basically epidemic that's happening with oropharyngeal cancer. We're going to talk a little bit about some of the new treatment options that have come up over the last 10 years or so, including a few words about robotics for head and neck surgery. And then I'll spend a few minutes, since it's such a hot topic, talking a little bit about immunotherapy as it applies to head and neck cancer as well, and specifically oropharyngeal cancer. So let's just spend a minute kind of getting on the same page about anatomy. The oropharynx really starts at the back of the oral cavity, so it starts at the rear of the hard palate, and so the hard palate ends about here. The soft palate begins. That's really the front of the oropharynx. It includes the tonsils, the tonsillar pillars, the back wall or the posterior pharyngeal wall, and then the tongue base. And looking at it from the side, the tongue base is here, soft palate is here. So this box, kind of right here, is really oropharynx. There's nasopharynx above, there's oral cavity anteriorly, and then there's the hypopharynx and larynx down below. So that's the zone that we're really focusing on. As I mentioned, it includes soft palate, tonsils, posterior and lateral pharyngeal wall, and the base of the tongue. And for the malignancies that occur in the oropharynx, 90% of them are either in the tonsils or in the tongue base. So when you're talking about oropharyngeal cancer, it's usually tonsil and tongue-based cancer that we're talking about. Some basic facts about oropharyngeal cancer. There's an epidemic of it going on right now, and we'll talk about that in a little bit. Overall, in the United States, all cancer cases have declined slowly over the past 10 years or so. This is SEER data, the most recent data available, and you can see just a gradual slight decline. Deaths from cancer have slightly declined over that time period. And here's the similar time period for, it's from the 1970s for tonsil and tongue-based cancer, so oropharyngeal cancer. This is tonsil cancer here, this is tongue-based cancer, and you can see that climb that's going on. In calendar years, again, overall, sorry, I'm having some pointer issues. Overall, HPV positive, papillomavirus positive oropharynx cancer in blue is going up, and overall, oropharynx cancer caused by smoking and tobacco is going down, but the overall rate is going up because of the HPV-driven type. And this just shows when HPV is looked for in those cancer specimens with in situ hybridization, that the presence of HPV has climbed as well. So it's not just that we're identifying HPV today when we weren't a few years ago. It's actually when they go back and look at the specimens, less specimens, 20 years ago had HPV in them than they do today. This chart from the American Cancer Society is illustrating that cervical cancer, which obviously occurs only in women, this is the average number of cases per year, around 11,000. And just this last year, in men with oropharynx cancer, that the number has climbed above the frequency of cervical cancer for the first time just in the last year or so with this change that's been going on. Oropharynx cancer overall affects about 1 in 95 adults. There's a 3-to-1 men to women ratio, which is still there. And historically, the risk factors have been tobacco and alcohol. So 75% of the patients at one point had heavy tobacco and alcohol use, and now that's really flipped. And I'll show some more data that way as well. Common signs and symptoms: mass in the neck is probably the most common that we see today. All of you who've dealt with these patients, I've seen patients come in with absolutely no other symptoms, and they say, Doc, I've had this thing in my neck for 4 weeks and it's just not getting better. What do you think? And so that's the most common thing that we see today. If you have throat pain, when they get to the point of having otalgia or ear pain or difficulty swallowing, the disease is typically much more advanced by that stage. These tumors are staged with a TNM system just like all others based on size, nodal status, and metastases, and the TNM staging system is changing, and it's effective in early 2018. The staging system for head and neck cancer is going to change pretty radically based on this HPV-driven oropharyngeal population. Overall survival rates overall for oropharynx cancer are illustrated here, and these also have changed with the advent of HPV-driven disease. So what's HPV? I mean, the most common disease caused by HPV is warts, right? It's papillomavirus, and it's a double-stranded DNA virus. There's a viral capsid around it, and then the DNA in the middle. There's over 100 subtypes that have been identified. Much like for cervical cancer, type 16 and 18 are the most common for head and neck cancer, and type 16 really for head and neck cancer is the one that most commonly received. The DNA in the virus codes for these capsid proteins that make up sort of the capsule, and then these E1 through E7 proteins affect gene proliferation and regulation, and they're the ones that are involved really in the pathogenesis. The E6 gene binds native P53, which is a tumor suppressor, and then E7 binds the retinoblastoma protein. It's also a tumor suppressor. So that's the mechanism of their oncologic behavior. The E7 upregulation, or the E7 expression upregulates P16, which is a protein involved in the process. And P16 is what the pathologists really look for to say that there's HPV present. It's a great surrogate and a cheaper way of looking for HPV in the specimen today. So almost always when we biopsy somebody, they report P16 status now, rather than whether it's truly HPV positive or not, because it's such a good surrogate. So as we mentioned, 16 and 18 are responsible for most cervical cancer and also a large percentage of the oropharyngeal cancers. There are a few other oncogenic subtypes, but those are the largest ones. So the incidence is increasing, and the patients don't fit the typical criteria. I mean, the patients that we typically think of with head and neck cancer are, are the guys that are veterans, right? That are smoke 2 packs a day and drink 2 6-packs a day, and crusty old dudes, and they're 65 or 70 years old, and I really love those guys. I mean, that's kind of why I went into head and neck surgery. I love dealing with those guys, but the patients who are getting HPV-driven oropharyngeal cancer aren't that same demographic. They're younger, and they frequently have little or no exposure to the known risk factors of tobacco and alcohol. So there's really emerged 2 distinct versions of oropharyngeal cancer. There's the HPV negative version, which is the tobacco and alcohol driven version that we all have seen for decades. Those patients are usually older, and they're usually male, and their prognosis is worse. And with HPV positives, they don't have the risk factors. They're younger patients, and their prognosis is overall much more favorable. So there's bad news that there's an epidemic of this. If there's any silver lining in it, it is the fact that the prognosis is better for these patients than it was for the HPV negatives. Just to show a little bit about incidence and all, and to the question of is HPV infection really increasing, or are we just recognizing it more today? The guys in Sweden went back and looked at all these tonsil biopsies from tonsil cancers over a 30-year period, and they saw increase in tonsil cancer HPV from 28 to 63% over that time period. In about 2007 in Sweden, 93% of the tonsil cancers were HPV positive. Probably not quite that high in the States, but it's pretty close. So some of the questions that are remaining at this point: why the epidemic? Why is it now and not 30 years ago? It's thought to be a sexually transmitted disease, as you know. They're thought to be changes in sexual practices and promiscuity and multiple partners and that kind of thing. Why it resides in the oropharynx and not in the larynx or the oral cavity, those are things that are not entirely clear. There's something about the microscopic environment in the lymphoid tissue, in the tonsils, and in the tongue base area that is just the perfect environment. And it's thought that the virus hangs out for 20 years or so and is latent for most of that time, and then eventually becomes oncogenic and develop and causes the tumor to develop. So only a small percentage of the patients that are exposed to an oncogenic strain of HPV virus will get cancer. So, and the thought is maybe it's 4%, something like that. And typically the latency is about 20 years between the time that they present and the time that they are exposed to the virus and the time that they present with the disease. So what does all of this mean for treatment and prognosis? Early stage head and neck cancer, oropharynx cancer, is no different. So stage 1 and stage 2 disease is treated very effectively by single modality therapy. And it can either be radiation-based treatment or it can be surgically based treatment. The numbers are pretty much the same, and we basically look at, which, in any given situation, what's going to give the patient the best chance of getting rid of the tumor and least side effects. So for a small cancer that's sitting on the tonsil that you can reach in and take out very easily, just almost doing a glorified tonsillectomy, those patients, you treat that if that's all the disease they have, they're done, and they really have very little in the way of morbidity from treatment. Others with big tongue-based tumors or something, if you cut that out, they have a lot of morbidity sometimes, and so they're treated preferentially with radiation, and the cure rates are felt to be very similar for early stage disease between the two. For more advanced stage disease, combination treatment is needed. So stage 3 and 4 disease, typically we'll use surgery followed by radiation, maybe plus chemotherapy, or combined radiation chemotherapy up front with surgery reserved for salvage. The treatment options, all of you have seen this, and this is basically kind of where we go at this point. The guidelines are updated yearly. These haven't changed dramatically for the last few years for head and neck cancer, but for stage 1 and stage 2 disease, they can, the guideline, I'm not going to print out the whole, or I haven't printed out the whole guidelines here by any means, but stage 1 and 2 disease treated with radiation or with surgery, 3 and 4 requires combined treatment. As we mentioned, HPV-driven oropharynx cancer appears to have a higher cure rate. The reason for that is not entirely clear. The molecular biologists look at these tumors, look at the numbers of mutations in the cancer, and they find that those that are caused by tobacco and alcohol are really heterozygous as far as numbers of mutations and density of mutations. So one cancer may have this mutation, that mutation, several others. And if you target the one mutation that's only there in a small fraction of the cells, you're not going to kill the whole population. In HPV-driven disease, the mutational load is much narrower, or the profile is much narrower, and most of the cells have the same mutations. So if you can find a way to target those cells and treat them, it often eliminates the entire thing. So that's one of the thoughts about why it appears to be easier to get rid of. Part of it probably has to do as well with the fact that the patients are younger and less comorbidities, they're healthier, they can tolerate treatment better also. So looking at survival for these patients, you remember the numbers that I showed you before that showed that the stage 3 and 4 disease survival rates were all below 50% and below for standard oropharyngeal cancer. For those that are HPV positive, if you look at these survival rates in a large RTOG study that was done, 3-year survival rates if they were HPV positive, 82%, and in this study, 57% if they were HPV negative. So pretty dramatic difference between outlook for those patients. All of these patients were stage 3 and 4 disease. Some slides here just showing the breakdown between overall survival if you're HPV positive versus HPV negative, and then progression-free survival, HPV positive, HPV negative. Those graphs really diverge once you get past a year. And P16, these other graphs just show that P16 is a really good surrogate for looking for HPV. If they're P16 positive, they're typically HPV positive most of the time. Again, survival curves, these are from Sweden, again, showing a clear breakout by HPV status. These are some of the larger studies that have been done to date looking at patients based on their HPV status. And you can see these 2 and 3 year survival rates in the 80 to 90% range. And that really was unheard of for advanced stage disease for oropharynx cancer before. So it seems to be biologically a different tumor. It's more sensitive to radiation, maybe more sensitive to chemotherapy as well. And we're still learning a lot about it. This is new stuff. And so the best treatment, can you de-escalate the treatment that they're getting? What role does chemotherapy have? You still use chemotherapy with radiation when you have extracapsular disease in the neck, and those kinds of things are all still being sorted out with clinical trials right now. So they probably can receive less toxic treatment and still have similar outcomes, and those studies are being completed, not yet reported really. So let's talk a little bit about some of the other treatment trends for these patients. We've been involved, we started in 2007 using robotics for head and neck surgery, and a large percentage of what we're doing that for today is oropharynx cancer, and I want to talk just a little bit about that and show you a little bit of our experience related to that. So for advanced oropharyngeal cancer, so patients come in with disease in their oropharynx, they usually have bulky neck disease as well. Standard surgical therapy was one of the open composite resections that everybody saw that in medical school or nursing school or something, tongue, jaw, neck operation, open thing, put a flap in, trach, patients in the hospital for a week or two. A lot of comorbidity just with surgery itself, a lot of recovery required to get over that. Still a great way to control the tumor, and we still do those operations often in salvage situations today. But when we can do something simpler and with less morbidity for the patients up front, we often do. Likewise, chemotherapy and radiation have historically been high dose. Patients get 70 gray of radiation with concurrent, cisplatin, Taxol, Erbitux, or something like that. And in the head and neck area, that is not easy treatment for patients to go through. Probably most of you have seen patients who are suffering side effects of that type of treatment. So whether you do the standard surgery for those patients or the high-dose radiation chemotherapy, there's some pretty substantial fallout from that for patients. So we've been using the surgical robot for this for a little bit, and I've got a few slides here just to kind of show some of the instruments and all. We use the sort of pediatric size or 5mm instrument for working through the head and neck. And basically for these patients, we arrange the arms of the robot and the camera and everything so they go through the mouth. And the machine's really not designed to work this way. It puts it, the machine's designed to work so that the arms are coming back towards it, and it's got a big open cavity that it's working in, and the optics are amazing and everything. In the head and neck, our whole limitation is really exposure. So can you get the machine in? Can you get things organized? And the machine itself is kind of having to work in this posture rather than back towards itself, so it's a strain on the equipment. It's not designed to work that way, but it has been effective, and the companies, coming out with smaller versions and a single port version that will allow you to get into the mouth. They're also going to be using this probably for urologic surgery and for colorectal surgery as well. It's sort of a snake type robot that will enter, and then little heads come out of the end of the main channel and allow you to work in a smaller area. Access has been our biggest problem. So as you guys know from working with patients, if you're looking in their mouth or you're trying to intubate them in the operating room or you're trying to, whatever, some people, they've got a full set of teeth and their jaw doesn't open very widely, and their mouth kind of goes about like this, and others, they open their mouth and they open like a snake, you can put your whole hand in there. So that it's really very patient dependent. We often can't tell until we get to the operating room really who's going to have a tumor that's accessible by this route or not. So we often will take patients to the OR with the idea in mind, okay, we're going to take this out if we can get access. But there are those that we still have to back away from just because access isn't there, they can't see the tumor well enough, and aren't comfortable with margin status. So this just shows a tongue-based tumor. The epiglottis is here, endotracheal tubes here, so this is right down in the vallecula, and retractor blades here, and you get a really good look at this, and it's nice. You can get this look sometimes with a laryngoscope and a laser, but you're working with only one hand. You don't have things to retract. You don't have an assistant sitting there that can suction things for you. So the field of view is much greater. It's a three-dimensional field of view, and you have more working hands to work on. And if the exposure is good, this is really a nice way for us to go. So we've looked at some outcomes using TORS as transoral robotic surgery. Most of this has been done for oropharynx cancer, and one of our residents a few years ago looked at clinical outcomes for these patients early on, and we compared those that were treated with primary radiation versus primary surgery. At this point, we had 27 patients in each group. These are just demographics. Staging of the tumors was fairly similar. There was not a lot of difference in these stages, and the patients that ended up having robotic surgery were a little less likely to need chemotherapy than the others. And they also were able to receive in average a lower radiation dose. And our experience with the radiation for these patients is if the dose can be kept to more of a post-op dose or a more of a moderate dose, somewhere in the 55, 60 gray range, the patient's side effects and chronic xerostomia and trouble swallowing, jaw problems and all of that are much better if the dose can be kept lower. So we also looked at PEG and trach tube use several months after treatment, and these were better in the patients that we did a minimally invasive operation on. One of our fellows looked at a combined series with our data combined with Mayo Clinic a year or so later, and there were 89 patients in this series, and 77 of them had an oropharyngeal. Primary overall recurrence-free survival for these patients was pretty good, up in the 80% range, comparable to what we showed before. There were some recurrences. 3 recurred locally, and 4 patients that recurred in the overall series had previously been treated with radiation or something else. So, in short, robotic surgery for oropharynx cancer is a minimally invasive approach. The concept's not new to anyone. It's just like other forms of surgery and everything. If we can do things by a minimally invasive approach and get the same outcomes, it's better for the patient, it seems. So their stay is shorter, they have better function, and equivalent survival, and potentially less radiation exposure than primary radiation chemotherapy. So there are multi-center trials underway looking at how you can change the treatment. Can you de-escalate the amount of radiation that they have? I personally think when these trials are finished that we're going to find that we may not need to operate on these patients. We're going to probably find that you can cure them with 60 gray of radiation, whereas if we operate on them up front and there's a concern about a positive margin, or they got multiple nodes in their neck, or extracapsular extension, or whatever, they're probably going to have radiation anyway in the same ballpark dose range. So in many of these cases, we may not be saving patients much in the future. Right now, they're required to get 70 gray radiation primary treatment, and we're probably saving something right now. I think my own thought is that for head and neck cancer, robotic surgery, and that sort of thing, eventually it's going to be more for patients that are HPV negative and not easily treated other ways, and for patients that are recurrences. So they've tried some other form of treatment, they failed, and you really have nothing to lose to try to go get that by a minimally invasive approach. If you're successful, you really help the patient. If you don't, then you can always go back and do the open composite thing that we've done for decades. I don't think I'll spend a lot of time with this. This is just details of one of those studies that's just completed. There's no data out on this. They just closed accrual, but they accrued close to 400 patients nationally, and the patients were treated with endoscopic or robotic surgery up front, and then they were stratified according to pathology risk factors, and those that had clear margins and no nodes or minimal nodes don't get any other treatment. Then they're looking at a low radiation dose. They're looking at a kind of a medium radiation plus chemotherapy, and then a high dose for those who have widespread neck disease, positive margins, lots of extracapsular disease, and that sort of thing. There's a non-surgical trial that's underway as well, looking at de-escalating radiation-based treatment for these patients. And again, that I won't go through a lot of details of this, but that study is underway and accruing patients. And I think when we get reports on all of that, there will be some differences in our recommendations of what we do for these patients. As far as prevention goes, I won't spend a lot of time with this, but there is recommendations from the CDC now that young men be vaccinated for HPV, just like young women, and it fairly clearly is effective in preventing this disease. I've talked to some of our GYN oncology colleagues and said, so when are we going to start seeing the decline, in cervical cancers and everything? And they kind of shake their head and they say, I just don't know that the penetrance of the vaccine is great enough in the population. I don't think enough people are using it that we're going to see much of a change for a while, which is unfortunate because it seems to be very effective with very little side effects. And so probably the same is true for men. I'm hopeful that the next 10 years we'll see all of those curves going back down rather than climbing, but we haven't seen that happen yet. And the GYN oncology guys that have been dealing with this a lot longer than we have are fairly skeptical that it's going to change anytime real soon. So the CDC does recommend that young men get vaccinated for HPV at this point as well. Final thing that I want to touch on just for a minute, and we'll leave time for a couple of questions, is immunotherapy for head and neck cancer. Immunotherapy is hot. Almost every time you turn on television, you see an ad for Opdivo or one of the immunotherapeutic agents, and we get asked about it all the time. It was interesting. One of the head and neck oncology guys that I worked with at one point is a basic science, really smart guy, way smarter than I ever was. And he's been involved with identifying some of the targets that these immunotherapeutic agents, the PD-L1, PD-1 targets that they're going after, and checkpoint inhibitors and all, and has been very much involved with the development of some of these drugs that are going on. He's got partial ownership in one of these companies that's developed these things, and I don't think he'll be practicing medicine much longer. He's making a boatload of money, I suspect. So for head and neck cancer, there have been some studies looking at immunotherapy for recurrent disease and for metastatic disease. And most of the studies at this point have been in patients who are kind of end stage, so they really don't have curative options from a surgical point of view. They've already been through radiation, they've failed, and then most of the studies have required that they fail a platinum-based chemotherapeutic trial, and if so, then they qualify for these studies with checkpoint inhibitors. Actually, these checkpoint inhibitors have been approved by the FDA for use in this patient population, and that's the only group that it's approved for currently for head and neck. But a couple of studies cited here, the unfortunate thing is that survival for these unresectable recurrent patients remains pretty low, and response rates with single checkpoint inhibitors, nivolumab and pembro, have been really fairly dismal. There were several studies that came out at ASCO this year looking at this, and I would refer you to a really nice review paper written by these authors that you can find on PubMed or whatever, that sort of summarizes this very nicely. But one of these was looking at pembro plus definitive chemotherapy and radiation as a phase 1 for initial therapy, looking at whether adding pembro improved response rates. They really, it's a phase 1 study, so we're mainly looking at safety and efficacy. Most of the patients were able to get through therapy without horrible side effects. It's too early to really tell if it improved their response rates at this point. There was a study reported that looked at pre-operative pembrolizumab, so patients that were planned for surgery, whether open surgery or robotic or whatever, they were given pembro up front, all stage 3 and 4 disease. These were HPV negative patients. As you'll notice here, 14 patients got the pembro, and 42% of those showed some partial tumor necrosis from that dose when they then resected the specimen. And less of the patients had high-risk features in the pathology than the institution saw previously. This was from WashU and St. Louis. So early data small cohort so far using Pembro as a neoadjuvant treatment. And then a combination study looking at Pembro plus this other agent, and this is not one that I've used at all. Sorry, my pointer's giving me issues here. But it inhibits IDO1, which is an intracellular immunosuppressing enzyme. So they use these two together, and you'll recall in the study that I mentioned at first, the response rates were only in the 13 to 18% range. Overall, with this combination, those response rates basically doubled, and the disease control rates were up to about 39%. And many of these, similar to what's been seen with other immunotherapy studies for lung cancer and melanoma and stuff like that, some of these response rates appear to be durable. So patients get a response to therapy, and you expect, okay, when's the hammer going to fall, and they're going to, the disease is going to be progressing again. And actually, there are a good number of them where the responses appear to be durable, which is encouraging. So early data, combination therapy. Right now, immunotherapy is only approved in head and neck cancer in those patients who have recurrent or metastatic disease, no other treatment options, and they failed platinum-based therapy. So those are the guys that it's approved for currently. Everything else is being done on clinical trial. So I think we'll stop there. We talked a little bit about HPV. We talked a little bit about robotic surgery, and a few minutes here about immunotherapy in the head and neck. I'd welcome any questions or yes.
Would you discuss metastasis in the light of what causes a person's death, and do you get direct involvement of the brain?
Yeah, so it's interesting with head and neck cancer being so close to the brain and everything. We get asked that a lot by patients as well, and it's pretty uncommon that the skull base and the dura get invaded, and it's very uncommon that head and neck cancer metastasizes to the brain. They typically metastasize the liver, lungs, bone, and usually the patients with metastatic disease die just sort of in initiation. They dwindle away from metabolic loss and nutritional depletion, and then they get weakened and they get a cold or something and turns into pneumonia. They can't fight it off, and that's kind of typically the pattern that we see.
So the liver's involved more than the thorax?
No, I would say probably the most common site of metastasis of distant metastasis is in the lungs, but liver is common.
Mediastinal?
Mediastinal nodes are very commonly involved, yes. Yeah.
Regarding the vaccine, most of the people in this room aged out of getting the vaccine before it became available.
Yeah.
But a lot of us spend a lot of time in the operating room getting exposed to surgical plume, laser plume, so on and so forth.
Yeah.
And, I get about 3 hours of smoke a day from thinking, should we be getting the vaccine?
Yeah, that's a really good question. I don't know that anybody can answer, should you get the vaccine? I've thought of that same thing. I don't have that amount of exposure to it, but that, the same volume that you have. I will tell you, I've had a couple of patients who were OBGYNs who've developed tongue-based cancers, and they've wondered the same thing. And I don't know the answer for you.
I remember when I was in the mid-'80s when I was working with the plastic surgeon. This was right after the CO2 laser came out.
Yeah.
And he said that this was in North Carolina. The OBGYNs were lasering warts left and right, and a lot of them got Oropharyngeal
Yeah.
from the laser.
Exactly.
That was before laser mask.
Sure.
So I don't do that, but I still worry about that. And I wonder periodically, should I do it?
Yeah, my understanding is that you're, and we've actually gone through this, in our own family with my son. I mean, he was a little older than the cutoff for the thing, but still clearly at risk. I mean, if you've not been exposed before and you're vaccinated, you gotta think it might help, so. Yes,
So I know that the screening process for the female population is obviously pap smears, but for the male population, is there a screening process?
there's not, people are working on that, we're actually kind of participating in a study that's, being done nationally at several different sites and, looking at oral swabs and that kind of thing, and, the concern right now is that, the virus is pretty ubiquitous in the population, and the incidence of patients who are exposed to the virus who actually get the disease is so low that simple presence of the virus doesn't always, well, it rarely correlates with disease presence. So it's, if you're looking for the virus itself, so you find it, what do you do with that? Most of the focus has been on dysplastic looking lesions and that kind of stuff. If somebody comes in with something like that, then you go looking for papillomavirus as maybe a cause. So, yes, sir.
Just a quick question. Do you think that the new immunological studies on the tumor itself is going to change staging of head and neck cancer, like with American Joint changing breast cancer staging, and now it has all the immunology that, down stages people if they have this certain genetic makeup?
Yeah, so the most recent staging system doesn't include immunologic markers, but it does include HPV status. And it includes some new things like depth of invasion for oral cavity cancers and things like that. So probably the biggest changes that we've seen in the staging system in the last 30 years came out with this most recent, but they're not including really biomarkers yet, other than HPV status. Thank you, guys. Enjoyed it. Appreciate it.